You're listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
How do we accurately assess sudden cardiac death risk in hypertrophic cardiomyopathy patients, and what role does non-sustained ventricular tachycardia play? On today's episode, Dr. Steve Ommen and Dr. Mark Link dive into the complexities of risk stratification, discussing how factors like age, VT duration, and scar burden influence ICD decision-making. They explore the evolving guidelines on NSVT, how to distinguish high-risk patients, and the latest advancements in ICD technology for HCM care. Tune in for an insightful discussion on one of the most debated risk markers in HCM management. Let's get in the thick of it. Here's Dr. Steve Ommen and Dr. Mark Link.
So Mark, nice to see you again.
Thank you. Thanks for having me.
Today, we kind of wanted to delve into one of the challenging aspects of managing our patients with HCM, and that is around sudden cardiac death risk assessment and identifying which patients might be eligible for ICDs. And specifically, we wanted to focus on non-sustained ventricular tachycardia. As we know, it's existed in guidelines and consensus documents for over 20 years as one of the things to consider or evaluate in our patients. But before we talk specifically about HCM patients, because I want to get there, but Mark, what is the significance of non-sustained VT in someone who's just coming into the clinic and they got a Holter monitor for something else? I mean, does the general population need to worry about NSVT?
Yeah, we actually see there's a fair amount of time that we get consulted for non-sustained VT. And in general, if they have normal hearts, we're not all that concerned because it's not prognostic for normal hearts. Now, if they have a dilated cardiomyopathy, certainly ARVC, HCM, we're much more concerned about non-sustained VT. But again, non-sustained VT in a normal heart is not that uncommon.
Yeah, it's interesting. And then, NSVT holds different places in different guidelines in terms of its importance. And we have kind of had it for a few iterations here in the North American guidelines is on its own. It is a class 2B indication for an ICD. So patients are eligible for an ICD if they have non-sustained VT, but it's kind of our weakest strength of recommendation. Do you feel like that's situated in the right spot, or is all VT the same? Are there more scary non-sustained VTs and less scary non-sustained VTs?
No, all non-sustained VT is not the same. And we know that from plenty of data on HCM and other diseases also. So in HCM in particular, the younger the patient, the more concerning non-sustained VT is. So certainly for those in their adolescent years, non-sustained VT is probably the strongest predictor of sudden cardiac death. And the pediatricians will implant an ICD. That's a 2A indication for a pediatric population. And other data have shown that it's probably up to age 35, it has prognostic significance. And after age 35, really doesn't have prognostic significance for individuals with HCM. But we know it's not only the age, it's the type of non-sustained VT. It's the rapidity of non-sustained VT. The faster the non-sustained VT, the more concerning it is. And the longer the non-sustained VT, the more concerning it is. So non-sustained VT is not all the same. I get referred a fair amount of patients that are 65, have hypertrophic cardiomyopathy, and have 3 beats of non-sustained VT. I'm not at all concerned about that patient. The risk for them is no different than the risk probably for anyone in the general population at that age. And I've talked to my pediatric colleagues a lot about that. If they see, a 14-year-old with 6 beats of non-sustained VT, that's almost more concerning than any other risk factor in the adult. So it really does depend on the age, the rapidity, and the length.
I agree with you. That 3-beat run of non-sustained VT is sort of like the bane of clinical practice because you're not sure what to make of that. Is there is there a number? Is it 5, 7, 10, or is it really, again, it's the whole picture you're looking at when you think about the length of the VT run?
Yeah, so we looked at this in our population with the Marins, and we dichotomized to the median, and the median was 7. And so we looked at less than 7 and greater than 7. And greater than 7 clearly was much more concerning than less than 7. But again, that's dichotomized, by the median. I think from a practical standpoint, it's more continuous. The longer the VT, the more concerning it is.
Yeah, I think that's right. And this steps into one of the tricky aspects of writing guidelines, because we're encouraged to put cutoff values there, but biology is not dichotomous or step functions in most cases. So I think we have to think about the continuum. And I think probably I want your comments on this too. What about the rate of the VT? I think technically we defined non-sustained VT as having to be at least 120 beats per minute for the guidelines document. So that means kind of an AIVR type thing wouldn't be counted as a risk factor, but the faster, the higher the risk seems to be as well. At least the more anxiety it causes me when I'm looking at that.
Yeah, we looked at this also, and again, the group of patients that we looked at was with Barry Marin in Minneapolis and then us at Tufts. So there was probably 550 patients that had ICDs. So all these patients had ICDs. And again, we looked at the median rate, and the median rate was 180. So if you looked at under the median rate, it was far less prognostic than over the median rate. But again, I do think it's a continuum. I'm not that concerned about, VT or AIVR 120 to 130, 140, 150, whereas 200 to 220 really starts to bother me.
Yeah, that's a good point. Does the morphology of the VT enter into your thoughts at all?
The only thing that enters my thoughts with that is whether it's polymorphic or monomorphic. If it's polymorphic, it's always more concerning to me than monomorphic. But in terms of monomorphic VT and where it's coming from, I don't think we have any data for that. We have data in normal hearts, or, if it's coming from the RV outflow tract, it's much less concerning. But I don't think we have that data for HCM patients.
Yeah, I don't recall any specific data on that either, and I would agree with you. When I see a polymorphic kind of rotating axis over a series of beats, that just seems like that sounds like a sicker cardiac environment to me.
Yes, for sure.
Historically, we have done 24 to 48-hour monitors historically, and now we are in an era where we have easier to use, easier to wear devices. So we're getting 7, 14, 30-day monitors. And that probably improves the sensitivity of detection, but does it change the predictive values when we're doing these more longer monitors?
Excellent question, and something I think about all the time, because the longer you monitor, the more likely you are to pick up non-sustained VT. But the traditional models were 1 day when they looked at the predictive value of non-sustained VT. So I don't know exactly what to do with this, to be perfectly honest. I think, the longer you monitor, the more non-sustained VT you're going to see. But it also gives you the opportunity to look at the rate and the number of beats. And so it does offer more. Again, 7-day monitors, you get a 3-beat run of non-sustained VT. I'm not all that concerned. You get an 8-beat, at 210 beats a minute, I'd be much more concerned.
We've been talking a lot about the VT in isolation, and that happens in not a small number of patients, but does it change your thinking or your approach when they have other SCD risk factors, hypertrophy greater than 30 or hypertrophy almost 30, or some degree of gadolinium enhancement on their CMR? Does that change your thinking or how worried you get about a VT episode?
Absolutely. We know that multiple risk factors, even 2, increases the risk for sudden cardiac death. So if you start adding on other risk factors, absolutely that bothers me, and it makes it more prognostic that they are at risk for sudden death. The one proviso again is those HCM patients that have made it to age 60, almost no matter what their risk factors are, they have a pretty low risk of sudden cardiac death. So again, you give me a non-sustained VT and someone that has, a septal wall thickness of 2.5 in a 65-year-old, that person I'm not that concerned about. You giving that in a 18-year-old, I'd be really concerned.
Do you think we should stop checking for non-sustained VT in patients who, let's just use a general term, older or elderly, and not to put a cutoff value? Do you think that there's a time where you just stop checking it?
Yes. I think that the data would show that over age 35, it's not prognostic. Now, you may go to 40, 45, but I think, once you go above 50, there's no value to non-sustained VT anymore. So I think it's time to stop checking, because at that point, it's not prognostic anymore.
Kind of going back to a prior question, so I have had a tendency to, if I get someone who the patient isn't quite sure they want an ICD, and they have, let's say, a significant amount of scarring on their CMR, that's a person who I might do more prolonged monitoring on them, because at least to me as a non-electrophysiologist, and you can school me where I'm wrong here, but to me, the scarring represents the substrate, and the VT is the thing you're looking for. And when I have those two things together, I almost add those together and make them a 2A kind of combination, again, in the right age patient, et cetera.
Yeah, so I have a couple of comments here. One is, yes, the younger the patient, the more concerned I'd be with scarring and non-sustained VT, for sure. But a bigger comment is that different MRI labs gain their MRIs differently. And so you can change the amount of scarring on an MRI from 5% to 30%. And I've had some of my patients, here that have 50% scarring. And that's not really compatible with life. So I think you have to really take the MRI enhancement with a grain of salt and say, what's our average read of our MRI radiologists? Because I think it's not as accurate as we think. And if you look in the guidelines, if you just have MRI gadolinium enhancement of greater than 15%, that still only gets you to a 2B. It doesn't get you higher than that if that's your only risk factor. So I'm very suspicious or, skeptical of just using MRI enhancement. But I agree, in a young patient with non-sustained VT and MRI enhancement, yeah, I'd be concerned.
Yeah, I mean, I think there's a pretty consistent theme that you're doing. Obviously, you've been an educator for a long time, so it's the younger the patient, the more significant all the risk factors are, and that's when you're going to be most worried. Let's shift a second to. We're going to extend our topic to device selection. So a patient who has decided they are eligible for and want to get an ICD put in for primary prevention purposes. What's kind of your mental algorithm you use for deciding transvenous, subcutaneous, extravascular? How are you approaching the evolution in ICD therapies?
Yeah, so there's no perfect answer and there's no perfect choice. The advantage of the transvenous systems are that the battery life is much longer. They're like 14, 15 years now. The disadvantage is the lead is intravascular, and also the lead is under the can at the shoulder. So every time the shoulder moves, the can goes over the lead. And so these leads will not last as long as a subcutaneous lead. The subcutaneous lead has a bigger can. It's twice the mass, twice the size, but the lead is not expected to wear out. I've never seen a subcutaneous lead break, never. But the other disadvantage is there are probably more T-wave oversensing in the subcutaneous device than there are in the transvenous devices. And the transvenous device can also ATP pace. Now, I don't think ATP pacing is valuable for the majority of HCM patients. I think it's the apical aneurysm patients that have a lot of monomorphic VT, whereas the garden variety HCM patients, it's predominantly VF, so ATP pacing is not going to make a difference. Now, I also want to, bring out a point about the new AV ICD from Medtronic. I think this potentially is a great device because the can size is the same as a transvenous. The battery longevity is the same as a transvenous. It's expected that the lead's going to be very durable. The one hesitation I have with the AV ICD is the P wave oversensing. And we know P waves are quite large in HCM patients. So I'm a little nervous about the AV ICD by Medtronic. I'm not against it. So I traditionally, if the younger the patient, would opt for a subcutaneous ICD because I think the lead is the real issue there. If the person has apical aneurysm, I'll opt for a transvenous device. Now, the other thing I think is very important is if you're going to put a transvenous device in, you really, really, really have to think about why would you put an atrial lead in. I see so many patients that had their ICDs put in as pediatricians, they get dual chamber ICDs. And then they come to me, they're 22, 23, 24, and it's their atrial lead that fails. And it's just, you really have to think about who's going to need a dual chamber ICD. I think they rarely need dual chamber ICDs and would strongly advocate in the transvenous population that they get single chamber.
Yeah, that makes a lot of sense. You brought up younger people getting ICDs. Most of the audience tends to be adult cardiologists, but can you just give us a little bit of insight into some of the extra decisions that go into someone who's a child or adolescent getting an ICD that isn't fully grown?
Yeah, there are a number of considerations. I think the biggest consideration is that non-sustained VT in that population is probably the most concerning risk factor. And that's been borne out in a number of studies. So that's very different than the adult population, where even under age 35, it's still prognostic, but it's not the most important. So pediatricians are very concerned, appropriately so, by non-sustained VT. And for their patients, depending on how old they are and how well grown they are, the subcutaneous ICD may not be a good choice because it's just so big for a small population, for a small body size. And so they get more transvenous ICDs than patients over the age of 18. I still think if they're full grown or nearly full grown, there should be consideration for the subcutaneous ICD. But it is a different patient population. And then you have the, patients that are 1 or 2 years old. That, I think, is a completely different population from garden variety HCM. Their risk of sudden death can be high, but these are difficult patients to take care of and difficult patients to implant ICDs in. And I applaud the pediatricians for that. I'm glad I don't have to do that.
Exactly. Well said. Well, Mark, this has been great. I don't get a chance to sit around and chat with an electrophysiologist, particularly one who knows as much about HCM as you do. And this has been really helpful to talk about non-sustained VT, one of our most problematic risk factors because of that difference across the age spectrum. And it's not just a yes/no phenomenon, but I appreciate you kind of walking us through your kind of expert views on that, and hope that the audience that's listening and watching to this found that as helpful as I did.
Great. Well, thank you for having me.
That was Dr. Steve Ommen and Dr. Mark Link. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you soon on In the Thick of It.